Thank you for joining me today to discuss the application of simulation models as operating practices in orthopedic surgery application at Hopkins Hospital. Improvements for optimizing the rate of surgeries and average patient flow time will be discussed. For our bottom line front, we recommend pooling the two operating rooms, pooling the anesthesiologists and surgeons, hiring 2 additional CNAs and 1 physician assistant, and increasing the inter-arrival time to 95 minutes. These operational enhancements are expected to decrease the average expected customer waiting time from 203.36 plus or minus 9.33 minutes to under 138.846 plus or minus 5.64 minutes. Surgeries are expected to increase from an average of 4.10 surgeries with a standard deviation of 0.27 to an average of 6 surgeries with no standard deviation per group per day. Patient-centered improvements must account for diverse cultural and socioeconomic perspectives. Regarding perceived waiting times by additional data collection on BMI averages, diverse hiring practices, inclusive decision-making, and implicit bias training to ensure equity in care delivery and operations. Here is our agenda for today. Let's take a look at the daily operations at Hopkins Hospital. The hospital runs 4 operating rooms organized into 2 groups, A and B, with each group managing up to 7 surgical procedures daily. The day begins at 7:30 a.m. and surgeries are scheduled with an inner arrival time of 9 minutes, ensuring a steady flow. The workday ends at 6 p.m. The surgery workflow described aligns most closely with the job shop process because of its high customization, flexible resource allocation, and non-standardized flow. Each surgery is tailored to specific needs of the patient, similar to custom order in a job shop. The operating rooms, staff, anesthesiologists, surgeons, and environmental services are shared and adjusted based on demand, resembling the flexibility required in a job shop. Patients progress through different steps: registration, anesthesia, surgery, recovery, in a sequence that may vary slightly. Much of the job moves through a shop based on individual requirements. The process involves registration, pre-op, prep, anesthesia, the procedure, and recovery, with most patients discharged the same day. Environmentally, the setup comes with challenges like surgeries often need to be rescheduled, especially towards the end of the day, leading to patient dissatisfaction and disruption to their plans. To address these challenges, an optimized workflow has been implemented by focus on standardized care processes. This ability between procedures, this streamlined approach not only improves the patient experience but also enhances the hospital overall efficiency and quality of care. Furthermore, Canuja has found that body mass index is a good predictor for time of surgery, but there is a question of whether BMI difference is something we can exploit operationally. We will not be distinguishing between hip and knee surgery. We scheduled 7 patients each at 7:30 a.m., and if a patient is unable to receive surgery, they are bumped to the next day associated with a dissatisfaction. As discussed further later in this presentation, we will be looking for process and innovations by looking at any logic models with the optimization functions, looking into maximizing profits and minimizing flow times for patients. Standardizing care processes has proven to be a key driver of quality and efficiency, ensuring better outcomes regardless of the hospital's or surgeon's procedural volume. While higher volumes are often linked to improved outcomes, they are not the sole determinant. We also care about the psychology regarding the difference between the actual and perceived waiting times, as well as overall patient satisfaction by minimizing the amount of patients that arrives at Hopkins Hospital and then have to return home due to it being the end of the workday. By understanding patient demographics and addressing operational constraints, we can uncover opportunities to ensure and enhance efficiency and patient flow. For example, leveraging simulation models, we can explore whether adjustments in resources utilization, such as adding or pooling staff or increasing or capacity, could increase throughput. We can also examine the impact of reducing variance in procedure in procedure durations, which might streamline operations further. Additionally, patients and family perceptions of waiting times can influence satisfaction, and addressing these perceptions through better communication or amenities could play an important role in improving the overall experience. These questions guides our exploration of how to optimize the workflow to reduce delays and increase the numbers of procedures completed in a single workday. Hopkins Hospital operates 4 operating rooms, or organized into 2 groups, Group A and B. A registrar pool for 2 staff members manages patient registration for both groups. Each OR group is supported by a dedicated anesthesiologist and orthopedic surgeon who alternate between 2 ORs within the group to optimize patient flow. Before surgery can begin, the OR must be cleaned and restocked with the necessary instruments by environmental services. 2 EVS staff members handle these tasks across all 4 ORs. These are one anesthesiologist for Group A and 1 for Group B. There's also 1 surgeon for Group A and 1 surgeon for Group B. There are no CRNAs or physician assistants. To the mean and standard deviation of the surgery time are 100.71 and 8.09 minutes, respectively. The analogic model above illustrates this process for the base case, with the table to the right summarizing the recent duration statistics for the key process stages, including registration, anesthesia, delivery, surgery, and housekeeping. Mean and standard deviation values for procedure are calculated using the weighted averages and variances detailed in the table in the upper right-hand corner. A total of 5 simulations were ran for the base case model in any logic, with the summary statistics reported for the register or in track A or in track B. Pooled ORs: anesthesiologist in track A, anesthesiologist in track B, surgeon in track A, surgeon in track B, physician assistant, and cooling utilization. As shown, the utilization for the anesthesiologists are high for both groups. The utilization for surgeons in both tracks, as well as operating rooms, also have concerning utilization rates. The biggest concern with high utilizations is needing to hire additional staff, as well as the concerns regarding burnout of current employees. Surgery is completed in a shift average to 4.1 surgeries per day per track, with a standard deviation of 0.27. The average flow time averages to 203.352 minutes, with a standard deviation of 9.33 minutes. The next case we explored was using the base case with a caveat of adding an additional CRNA. Here is the any logic model simulation has highlighted the input for the NUM CRNA underscore pool increases to 1. And a total of 5 simulations were ran for the case in any logic, with the summary statistics reported for the utilizations. Number of surgeries in each track and the average flow times for surgeries completed in a shift average to 4.9 surgeries per day per track, with standard deviation of 0.27. Which is almost 1 surgery track higher on average than the base case. The average flow time averages to 188.705 minutes, with a standard deviation of 10.45 minutes, which is slightly less average flow time than the base case, about 203 minutes. The utilization for each anesthesiologist decreased about 81% compared to the base case of about 89%. However, the utilization of the surgeons increased for the base case, which is undesirable. To combat this issue of surgeon utilization, in this next case, we explored adding both an additional CRNA and a physician assistant. The any logic model shown above has shown the OR utilization is now becoming problematic. The surgery is completed in a shift average increased dramatically to an average of 5.7 surgeries per day per track with a standard deviation of 0.42, which is almost one surgery per track higher on average than the last case, with only one additional CRNA and almost two surgeries per track more compared to the base case. The average flow time also decreased. The average flow time also decreased to 161.945 minutes, with a standard deviation of 13.67 minutes. The utilization for each anesthesiologist is consistent with the last case explored, and the utilization of the surgeons decreased drastically from the last case as well as the base case. So far, we are doing pretty great in terms of process improvements for the number of surgeries completed per day, but we could still explore how to reduce the average flow times. In this next case, we are going to explore pooling ORs and anesthesiologists to see if pooling matters. Adding two CRNAs pooled. Note that this represents two anesthesiologists pooled. The surgeries completed in the shift average decreased dramatically from the last two scenarios to an average of 4.2 surgeries per day per track with a standard deviation of 0.36, which aligns with the base case. The average flow time follows a similar trend of increasing from the last two cases, but decreasing slightly from the base case to 192.608 minutes. With a standard deviation of 9.42 minutes, pooling does matter in this case, but additional resources needs to be added to the surgery procedure to get the desirable amount of surgeries raised and average flow times decreased. Next, we are going to explore if groups A and B categorized by BMI matters. The two groups were divided in half based on weighted average of the patient population's BMI. The weighted average was then accounted for when determining the variance square of weights and resulting mean and standard deviation. This is the analogic model as highlighted in yellow. The mean and standard deviation for both surgery tracks are changed. The surgeries completed in the shift though does increase slightly to an average of 4.3 surgeries per day per track with a standard deviation of 0.42 from the base case. The average flow time aligns with the base case of 204.319 minutes with a standard deviation of 12 minutes and 12.82. The BMI classification does increase the number of surgeries, but doesn't address our need of decreasing flow time. Additionally, this scenario raises several concerns with diversity, equity, and inclusion, as obesity is disproportionately affecting some gender and race with limited data and may introduce bias into their treatment. The surgeries completed in a shift does increase slightly to an average of 4.3 surgeries per day per track with a standard deviation of 0.42 from the base case. However, the average flow time significantly decreases from the base case to 149.247 minutes with a standard deviation of 9.76 minutes. Although this situation does not increase the number of surgeries, it does help with decreasing the flow time and patient satisfaction due to not having to send home patients who arrived later in the day at the office. After running the optimization model to account both for cost and patient waiting and cost of hiring additional staff, the optimal solution was determined to be pooling the operating rooms, anesthesiologists, surgeons, increasing the arrival time to 95 minutes and hiring an additional CRNA and an additional physician assistant. Here is the optimization tool ran into AnyLogic. This slide captures the additional scenarios considered and their resulting utilization surgeries completed in each track and average flow times in each tracks with running 5 simulations per scenario. Here is the AnyLogic model used for the ideal case of pooling ORs and anesthesiologist surgeons and increasing arrival time to 95 and hiring 1 CRNA and PA. The surgeries completed in a shift increases to an average of 6 surgeries per day per track. The average flow time significantly decreases from the base case to 138.846 minutes with a standard deviation of 5.64 minutes. This model also reduces the variation of the operating rooms, anesthesiologists, and surgeons to a significant extent to help ensure that staff members are being utilized without running the risk of burnout or overutilization. The arrival time was also slightly increased to 95 minutes to take into consideration patients waiting at the end of the day and mitigating the risk of having them be rescheduled for the following day. Note that this option does assume that there's an additional budget allowed for hiring 2 additional staff members of the CRNA and a physician assistant. It also assumes that the surgeries allow any surgeon and anesthesiologist to be involved in the patient care. Overall, this scenario illustrates how both pooling and utilization matters, variance hurts, and psychology matters. Average surgeries completed per day per group before improvement is 4.1 plus or minus 0.27. After improvements, pooling ORs and anesthesiologists/surgeons and increasing arrival time to 95 and hiring 1 CRNA and PA increases the average surgeries per day to 6 with 0 standard deviation. The average patient flow time decreases from 203.362 plus or minus 9.33 minutes to 138.846 plus or minus 5.64 minutes. With the improvements, initially the bottlenecks were pre-op prep and anesthesia. With high utilization of anesthesiologists, this bottleneck was mitigated by adding additional CRNA and pooling the anesthesiologists. After this improvement, we saw a drastic increase in utilization in surgeons, so we added an additional physician assistant and pooled the surgeons. We increased the inter-arrival time to help with patient satisfaction, as well as pool together the operating rooms to help with this utilization. This case raises several diversity, equity, and inclusion concerns related to patient care, workforce dynamics, and systematic practices. Patient access to care may be inequitable, and most procedures are performed on Caucasian patients with limited data on other racial or ethnic groups and barriers like socioeconomic status potentially affecting care access for marginalized populations. Obesity disproportionately affecting some groups may introduce bias in treatment. Workforce representations and inclusivity are also a concern, as roles like EVS staff and registrars may face inequitable workloads, and there's no mention of workforce diversity. Additionally, patient-centered improvements must account for diverse cultural and socioeconomic perspectives, especially regarding perceived wait times. Missing data on race and the emphasis on averages obscure disparities, while standardizing care processes might inadvertently overlook specific needs of underrepresented groups. Addressing these issues requires better data collection, diverse hiring practices, inclusive decision-making, implicit bias training, and strategies to ensure equity in care delivery and operations. Thank you for listening. Please reach out with any questions.